Hi there, my name's Andrew Martin. I'm Associate Professor of Biostatistics at the NHMRC Clinical Trials Centre at the University of Sydney. And I'm going to be talking with you about Phase 2 clinical trial designs. We're going to look at what the purpose of a Phase 2 trial is, as well as unpack some of the strengths and limitations of common Phase 2 trial designs. So where does a Phase 2 trial fit in the development continuum for new intervention? Well, not surprisingly, it fits in between Phase 1 and Phase 3. And you can think of Phase 1 as being an initial assessment of an intervention's feasibility. If it was a drug, it might be looking at the feasibility of achieving a particular steady state concentration using a particular regimen. It might, if it was a diet and exercise lifestyle intervention, then it might be the feasibility of actually adhering to the intervention. So Phase 1, it's all about determining feasibility and optimizing the delivery of an intervention. Let's jump to Phase 3. Phase 3 is all about determining whether an intervention is ready for use in routine clinical practice. So Phase 3 studies are designed to give very definitive evidence that allows one to make reliable decisions about having a new intervention used in practice in place of what had been used previously. Okay, so sandwiched in the middle, we've got Phase 2. What are they about? Well, they represent a stepping stone between the assessment of feasibility and the determination of net clinical benefit and role in routine clinical practice. Phase 2 studies are designed to follow on from Phase 1 that have shown feasibility, and their focus is on determining whether the intervention has a sufficiently promising level of activity and safety to warrant further evaluation in a Phase 3 trial, which will typically involve or require a large amount of time, effort, resources, patient participation. And given the size of a Phase 3 evaluation, it's got the potential to expose large numbers of patients to an unproven experimental treatment. So the Phase 2 is very critical for providing solid evidence that an intervention appears sufficiently safe and it has activity on some endpoint that is believed to be indicative of what the intervention's effect might ultimately be on a clinically definitive or patient-centered endpoint. We're going to talk about endpoints on the next slide or two. So in terms of some of the characteristics of a Phase 2 trial, they'll generally have a more moderate sample size than a Phase 3, and there's a couple of, at least two reasons, probably more reasons for that. One is that the strength of evidence may not need to be so definitive as it does in the Phase 3 setting, because the stakes are different. The consequences of reaching a incorrect conclusion, well, the consequences in the Phase 3 setting are potentially dire, but less so in the Phase 2 setting. So another reason they can generally have a smaller sample size is that they are looking at an intervention's activity on some intermediate endpoint that has been chosen because of its likely sensitivity to the effects of the treatment. So an example in oncology of an intermediate endpoint could be tumor response, tumor shrinkage, or maybe even progression-free survival. And it's intermediate in the sense that it is removed from a more patient-centered outcome, such as quality of life, so the patient's assessment of their own well-being. And it's also removed from definitive clinical endpoint, such as survival. So I've talked already about intermediate endpoints being of interest in phase 2 because of their likely sensitivity to the treatment effect. And this increased sensitivity is going to mean fewer patients will need to be enrolled in the phase 2 because more prominent treatment effects require more modest sample sizes to be detected. Now, when we talk about an intermediate endpoint, we're really hoping that this intermediate endpoint is a good surrogate for a more definitive endpoint, such as overall survival. And if an intermediate endpoint is a good surrogate, then it provides a good substitute for that definitive endpoint. So as an example, we might decide in our phase 2 study to use tumour response as the primary endpoint. It's an intermediate endpoint, and we're either hoping or we've got good evidence that it is a good surrogate for survival time. So if we can demonstrate some activity on tumour response, that gives us some confidence that in a phase 3 evaluation, we'd be able to pick up an effect on overall survival. So in order for that to hang together, in order for an intermediate endpoint to be a good surrogate, it needs to be more than simply correlated with the definitive endpoint. So it's not simply tumour response is correlated with survival time. It's that the effect of the intervention on the intermediate endpoint predicts the effect on the definitive endpoint. So we see that relationship in a little diagram here where we've got the disease and a pathway from the disease process through to the definitive endpoint. Let's call it overall survival. We've got the intermediate endpoint in the middle here, and we can see the intervention is acting on that particular pathway. And so its effect on the surrogate is going to be borne out by an effect on the definitive endpoint. Now, there are plenty of examples of where what was thought to be a good surrogate endpoint turned out not to be. And an example is presented on this slide. And we begin by kind of acknowledging that ventricular arrhythmia is associated with an increased risk of death from cardiac complications. And so suppressing these arrhythmias, you would think, should lead to a reduction in or an improvement in survival time. And indeed, the CAPS study showed 2 particular agents were effective in suppressing arrhythmias. And that particular study and the evidence it generated formed the basis of a follow-on study, phase 3 trial, where these drugs were being tested in terms of their effect on overall survival. But actually, although these drugs had activity in terms of suppressing arrhythmias, that turned out to be a very poor surrogate in this setting because the drugs ultimately were found to be harmful. And so the risk of death associated with the drugs was increased compared to placebo. So there are plenty of explanations for why an intermediate endpoint might not end up being a good surrogate. It may be that it's the surrogate or the intermediate endpoint is simply not on the pathway from the disease through to the definitive endpoint of interest. It may be that the intervention does affect the definitive endpoint, but it doesn't affect the surrogate endpoint. And there are a couple of other combinations or possibilities for failures of surrogates on this slide. I won't go through the other two. But I will talk about an example of some evidence supporting metastasis-free survival as a good surrogate of overall survival in localized prostate cancer. So this is a slide from the IceCap initiative published in JCO. And this particular slide is showing evidence from 19 trials with over 12,000 patients. And on the horizontal axis, we've got a measure of the effective treatment that was being evaluated in each of the 19 trials, a measure of the effective treatment on metastasis-free survival, and that measure is a hazard ratio. So a smaller hazard ratio is indicative of a more favourable treatment effect. And then you can see the hazard ratio for overall survival on the vertical axis. And each of these circles represents an individual study, and its size reflects, the size of the circle reflects the relative number of patients in each of the studies. And there's a very strong relationship between the effective treatment on metastasis-free survival and the effective treatment on overall survival, such that one could predict that if the treatment had led to a hazard ratio of 0.6 on the MFS endpoint, then we could sort of look up the slide, hit the yellow line, then move across, and I think we end up at something like 0.65 or 0.67. So it's a weaker effect on overall survival, but nevertheless, there is an effect there. So this is an example of some good evidence for MFS being a good surrogate of overall survival in this particular indication. Okay, so we've talked quite a bit about intermediate endpoints, surrogate endpoints, and their role in a phase 2 setting where we're trying to determine the activity of a treatment on a particular endpoint, and that the intermediate endpoint that's chosen will be chosen because it's thought to be most sensitive, or one of the reasons it'll be chosen is because it's believed to be sensitive to the treatment effect, and that means a smaller sample size will be needed to detect it. So that provides some efficiency for our phase 2 trial. Efficiency meaning we can get away with fewer patients. So the next thing I want to talk about are the criteria that we'll need to have in place for reaching a go, no-go decision on the basis of a phase 2 trial result. So we need some criteria for determining whether to proceed to phase 3. And we'll look at examples of designs where we specify criteria that distinguishes a level of activity that's interesting and sufficient to warrant further investigation versus not. Now, we'll talk, in fact, in a second presentation I've provided for the workshop, there's information on sample size, and I'm not going to dwell on that in any formal way now. And I just want to put to you that when reaching a go, no-go decision, there's a risk of making an error where we continue research on an intervention that's actually ineffective, and that's known as a type 1 error, and the probability of making a type 1 error is specified as alpha. And there's also a risk of incorrectly abandoning research on an intervention that's actually effective. So that's a an example of another type of error, type 2 error, and the probability of making a type 2 error is beta. Now, when designing a trial, the more you endeavour to drive down the probability of a type 1 or a type 2 error, in other words, the smaller the alpha and beta you plug into your sample size calculator, the larger the trial will need to be. So that's probably sufficient on sample size for the time being, but there's another talk coming up which provides more detail. So let's now apply what we've heard about to a situation where we have a single arm trial. So with a single arm phase 2 trial, there's no comparator arm. We need to pre-specify some benchmarks against which we're going to evaluate the observed result. And so we would specify, for example, P1 as what constitutes an interesting success rate, P0 as what constitutes an uninteresting success rate. And then we would be specifying the alpha and beta we were prepared to live with our study. And we then have our design. At the conclusion of the study, we then evaluate the observed success rate against the benchmark and decide whether or not we've got a result that is superior to the uninteresting success rate, this P0. So, you know, straightforward, statistically efficient. It gives rise to sample sizes that are smaller than a randomized controlled trial. But as you'll have spotted, the validity of the conclusions really hinges on the correctness of the reference rates that have been specified a priori. And these sorts of benchmarks will be informed by previous studies, perhaps historical controls, and there'll necessarily remain some question on whether the historical data that's informed the benchmarks is, or the benchmark is appropriate in a modern context. So here's an example of that design being used. The Integrate 1 study, Regorafenib in advanced gastric cancer. The primary endpoint was it was a single-arm study. The proportion of patients that were alive and progression-free at 2 months, so 2 months PFS. A priori, and the interesting success rate was defined as a 2-month PFS of 66% or 0.66, and an uninteresting success rate was defined as a 2-month PFS of 0.5 or 50%. And we've got our alpha and 1 minus beta power plugged in there. And we end up with a design that requires 81 patients in our single arm study and a go, no-go rule where the uninteresting success rate, so this one, 50%, is declared as implausible if we see at least 48 successes out of the 81 patients. So this is an example of a single arm phase 2 design without any provision for early stopping on the basis of emerging evidence. And let's now reflect on designs that do allow for some interim evaluation of emerging evidence. And that can be very useful and appropriate in a phase 2 setting where we're needing to establish a balance between enrolling sufficient numbers of patients to obtain reliable evidence whilst minimising exposure to a potentially ineffective or even harmful treatment. And so having a built-in opportunity to halt the study early due to inefficacy it can be very important. So let's revisit in a moment. We're going to in a minute revisit the Integrate example and look at it from the perspective of a single-arm trial that is carried out in 2 stages. And this is Simon's 2-stage design, where we have a binary endpoint of success, treatment success. And as we enroll patients to the first stage, we look at the number of successes out of the number of patients enrolled in the first stage. And if we see a sufficient number of successes, then the design continues to stage 2. And if we do not see a sufficient number of successes, the study terminates early. So let's look at that for Integrate. We've got basically the inputs remaining the same, but we now have a 2-stage design and a rule that says if we see 16 or more failures in the first 33 patients, then we stop for futility. However, if we don't, we continue. And if we end up seeing 53 successes out of a total of 92 patients, we will end up declaring the uninteresting success rate as being implausible. So that would then become a go decision for phase 3 evaluation. So note that the sample size for a single stage design, in this case is 81, but it's a bit more for the 2-stage design. And there are some different ways of kind of fine-tuning 2-stage designs, which means that you're not always going to see such a relatively large jump in sample size requirements, but you will see some increase usually in sample size requirements going from a single stage to a 2 or more stage design. Okay, now let's move on to talk about phase 2 trials with more than a single arm. And the first type I want to talk about is the randomized calibration design. Sometimes this is called a randomized non-comparative design. And the basic idea is that patients are randomized to either an intervention arm or a calibration arm. In the calibration arm, they get standard care. In the intervention arm, they get the experimental treatment. Now, those that are randomized to the experimental treatment, their data get appraised as if they had been collected within a single arm trial. So the techniques that we've looked at already for Integrate would be applied to the experimental arm of this randomized design. So what's the purpose of randomizing patients to a calibration arm? Well, the data, the evidence from the calibration arm help us decide whether those pre-specified benchmarks are credible and appropriate. So we had a priori said that a 2-month PFS of 50% would be indicative of an uninteresting success rate, or put another way, that's the success rate we would expect given control therapy, or given standard care, which at that time was placebo plus best supportive care. And the calibration arm, the inclusion of the calibration arm, allows us to assess whether this benchmark is an appropriate reflection of contemporary outcomes for patients that end up receiving standard care. So now let's look at Integrate once again, which was ultimately designed as a randomised non-comparative trial, so one of these calibration designs, and 150 patients were enrolled, randomised 2 to 1. So we had 100 in the Regorafenib arm and 50 in the placebo arm. Oopsie. And that design gives us a sufficient number of patients in the Regorafenib arm to implement one of these Simon's two-stage designs with an appropriate specification of alpha and beta, and it provides about 50 patients to help us understand whether our choice of reference rate is appropriate or not. Now, I want to just take a moment to acknowledge that, you know, the single arm trials and even the randomized calibration type design, where we're focusing on just the experimental arm when doing our evaluation, these ideas can be extended to other settings such as basket trials, where we have multiple types of cancer but a common molecular target, and a particular drug, the activity of a particular drug is being evaluated in each of these different cancer types with a common molecular target or mutation. Now, one way of thinking about this is to consider each of the different cancer types as being its standalone single-arm trial, like a Simon's two-stage design. And there is a master protocol that overarches all of these individual single-arm trials. And the way I've phrased it, the way I've explained it, would mean that each particular basket, so each individual cancer and the activity of the drug in the cancer, would be evaluated separately, which makes sense if there is evidence of heterogeneity of effect across the different cancer types. But these basket trial designs also have the potential to pool information across baskets if there is no heterogeneity of effect. And so that can lead to improvements in estimation, because we're getting more patients contributing to a common estimate of effect. Okay, so just a little bit about how we could jump from some of the single arm designs that I've covered so far to basket trials, where the effect of a particular intervention is being evaluated across different cancer types, but all with a common molecular target. Okay, now let's move away from studies that have an emphasis on single arm designs and talk about randomized comparative designs in the phase 2 setting. So I've talked about how single arm designs will be more efficient than RCTs, meaning you can get away with fewer patients. So as soon as we start talking about RCTs, an RCT design, a randomized control trial design in the phase 2 setting, we've got to acknowledge that that's likely to drive up the sample size. But one of the levers we can manipulate to reduce the sample size is this choice of alpha and beta, so those probabilities of making a type 1 and a type 2 error. Now, an experimenter or an investigator has some wriggle room in specifying alpha and beta for phase 2, because the stakes of reaching an incorrect conclusion will be lower, or the consequences will be less concerning in the phase 2 setting compared to the phase 3 setting. So in phase 3, alpha and beta are typically small values that are widely accepted, but in phase 2 there can be some wriggle room, and so the bigger these are made, the smaller the sample size need be. So here's a little example of a phase 2 trial of famotidine for improving walking distance in patients with multiple sclerosis. And rather than so this was a randomized design, so it's famotidine versus placebo, and rather than using an alpha of 5%, which would be very conventional in the phase 3 setting, an alpha of 10% was used for this phase 2 setting. And ultimately the p-value from the primary analysis from this trial was 0.08. So that falls above the commonly used 5% level of statistical significance. But because a 10% alpha was pre-specified, the conclusion is that further evaluation should be performed, because the observed p-value of 8% is below the pre-specified threshold of 10%. So, let's now return to what actually happened with our Regorafenib study in advanced gastric cancer, so the Integrate trial. And I talked about how a randomized calibration design was used. If I flip back to it, we had pre-specified an expectation that the control arm would have a 2-month PFS of about 0.5. Now, what actually happened was, if you look at the blue line here, this is PFS curve. The blue line is for placebo. The 2-month PFS in the placebo arm was much lower than 0.5. It was closer to 0.2. So this is an example of how our calibration arm has revealed that our pre-specified benchmark of a 2-month PFS of 0.5 was way off. So we therefore knew that it wouldn't be appropriate to simply evaluate the 2-month PFS in the Regorafenib against that 0.5 benchmark, because it's inappropriate, it's poorly calibrated. So what we ultimately did is a comparison between the two arms. And this was somewhat controversial because the design was pre-specified as a non-comparative randomized calibration design. But because we could see that actually following through on that design would be silly, because our benchmark of 2-month PFS of 50% was so wrong, we were able to make a strong case for a head-to-head comparison, and we obtained a very small p-value for that comparison, very compelling evidence that Regorafenib had activity. And that, in fact, led to the launching of a phase 3 trial of Regorafenib in this indication, with a primary endpoint of overall survival. So we've moved from PFS in the phase 2 setting as an intermediate surrogate endpoint to overall survival in the phase 3 setting. Okay, so let's wrap up. What have we been talking about? Well, we've focused on what the purpose of a phase 2 trial is. It's to see whether definitive evaluation is warranted, whether it's worth investing a lot of time, effort, money in doing a thorough evaluation relating to net clinical benefit to inform future clinical decision making. Phase 3 trials are all about gathering evidence to determine whether that further evaluation is worthwhile and demonstrating the activity and safety of the intervention. We talked about intermediate endpoints and how these can be of interest in phase 2 because they can be especially sensitive to treatment effects. But we also talked about the concern over whether a intermediate endpoint is actually likely to be a good surrogate. So is a reduction in arrhythmias actually going to lead to a reduction in deaths? We looked at single-arm trial designs and we learned that they're efficient in that we can get away with fewer patients, but they're susceptible to bias in that we evaluate what we see in our single-arm study against a pre-specified benchmark informed by historical controls. And we saw it from the Integrate example how we can get that quite wrong and that our pre-specified benchmark might be quite poorly calibrated. And then that brought us to a discussion of randomized phase 2 designs. We talked about randomized non-comparative calibration design, like the one used in Integrate, but also conventional head-to-head randomized phase 2 designs where we might be using a more liberal specification of alpha and beta to drive down the sample size requirements. And a randomized comparison is going to provide more valid evidence than